If you look back at the 80s, if somebody came, or early 80s or late 70s, if somebody came in and they'd been hit on the head and got knocked out, what did you do with them? For those of you that are old enough. Observe them. You would admit them and observe them. Why? Because we didn't have a good test. Same thing for pulmonary embolus. Even in the late 80s, about 2 or 3 times a day you'd admit somebody for a rule-out PE because you had no good test. And as we got better tests for a lot of these diseases, fewer and fewer of these patients were admitted. I'm Peter Viccellio from Stony Brook. Hello. Actually, what I've been promoting is more complicated than what Rick is saying, because what I've been promoting is taking patients and moving them from hallways to hallways. That's a more, if you're outside of healthcare, it's very difficult for people to understand how this is a revolutionary, think out of the box idea, but nonetheless. So there's other problems that will relate. So anyway, we have a problem of how do we diagnose all these chest pains that come in. For us, we live in this bizarre environment where there's nothing that we can do that's right. We do tests in the emergency department for what reason? Think about it. We get cardiograms, we get troponins, all that sort of stuff. What question are we trying to answer by getting that stuff? What we're really trying to answer is the following question. Do I have to think about this case? Because if either of those are positive, you don't have to think about the case. You just admit them. So, and for those that are left, we have to really struggle with whether or not patients need to come in or is it safe to send them home. And we work in an environment where we have an intolerably low acceptable miss rate. If you're sending home 2% of your MIs, if you look at a full-time emergency physician, the number of chest pains they see, multiply that by the 2% factor, then and look at the ones that go home and the percent of those that die. When you go through that whole calculation, you end up sending home one person who will die every couple of years. And that's too high for us. Once you've practiced emergency medicine for 10 years, it's hard for you to get a job because you've got a whole bunch of malpractice cases chasing after you for sending people home. Yet on the flip side, once they're admitted, how do they use troponins and cardiograms? Well, if they're normal, they don't need to think about the case. So things are suddenly inverted once they get to the inpatient service. And why were we so stupid to even have admitted them to begin with? How many of you are able to get stress testing out of your emergency department? So just 9 to 5, or you can get it in the evenings too? And weekends? Yeah. That's a whole other discussion about how we continue to be a 9 to 5, Monday through Friday business, although we're trying to fit a 7-day-a-week problem into it. Because we don't know what we're doing, we actually had a cardiologist on service one month come down and look at every single one of our chest pains when he was around. And he was around in the hospital a lot, so it's about 12 hours a day. And in that 1 month period of time, he sent home 42 patients that we would have otherwise admitted. Interestingly, of those 42, 8 returned with an acute MI, except for the 2 of the 8 who died. And they ended that experiment of having because it was far easier and actually more emotionally satisfying for them just to criticize us the next day for our unnecessary admits. So that worked well for them. Anybody familiar with Joe Arnotto? He's the chairman of emergency medicine at Richmond. In Richmond, he's a great guy. He's a cardiologist who segued into emergency medicine. And he has this big workup protocol in his emergency department. And this is not with CTA, but it's with other testing. And this is how it works. You get all the routine stuff we normally do. We get troponins, we get cardiograms, whatever else. But in addition, if you're actively having chest pain right now, you get injected with sestamebe. The way sestamebe scans work is it distributes according to coronary flow. So if you have areas of decreased flow, you have areas of decreased uptake on the scan. And once you inject the sestamebe and it redistributes, it sits like that for the next 3 or 4 hours. So you don't have to send them for a scan right now. You just have to inject them right now while they're having pain. And you scan them sometime in the next 2 or 3 hours. If your pain is coming from your heart, that test is going to be abnormal over 90% of the time. Why not 100% of the time? Because sometimes the areas of abnormal perfusion are so small that you just don't pick them up on the scan. It'll be a distal little tributary. But in terms of the major scans, this is an excellent way of picking up coronary ischemia. Yeah?
Radiology or cardiology?
The answer to that depends on your institution and politics. One of our private cardiologists suggested that we actually get the machine ourselves and that we ourselves should undertake the extensive training to read these scans, which he said would be somewhere between 30 and 45 minutes, and then we could just do it ourselves. But that was too much to ask of us, so we elected not to. So the other part to this is when he's if you don't have if your scan's normal and you're having pain and your cardiogram's normal and your troponin is normal, you're done. You go home. If you're not having pain at the time, then the resting sestamibi is not helpful. So he gets a second troponin and then gets an exercise stress test in the emergency department. If they're normal, you go home. If abnormal, you get admitted. These are the overall results of his effort to do this. Misclassified 1 in 1,200 patients. And the one that everybody cites that they're interested in is that they decrease the number of admissions by 25%. The second number, which people don't pay attention to, is that they increase the number of interventions by cardiology by 20%. So what this means compared to before establishing these protocols, yes, indeed, they were able to send a lot home. But the other thing he found was that a lot of people were previously being ignored that had serious problem. And that by doing this workup in the emergency department, they picked up an additional 20% that they weren't doing on the inpatient side. Now, we took a look at our own institution, 400 patients in the following environment. We used to have an average census of 65 cardiac patients in our institution on the inpatient service at any given moment. So in order to better care for cardiac patients, we built a 35-bed heart center. Now, I don't know what drug the planner was taking, but we're going to expand from 65 patients to 35 patients. So we had to sort of pick and choose who went to the heart center and who went to the medical floors. And what we found is if you're admitted to the heart center, you got a complete workup. If you're admitted to the medical floors, more than 80% were not only discharged without a workup, but never got a subsequent workup in the 3 months of follow-up. They never got a stress test or any kind of assessment. They were just discounted as having nothing. So this is the context that we work in, is that one, we can't afford to miss one of these cases. Two, our instruments for diagnosis are stunningly insensitive. The stuff that we would like to do, like sestamibi, stress, and all that sort of stuff, in a lot of institutions is only available 9 to 5, Monday through Friday, and we don't have another good way of doing this. The other part to this is once they get inside, they just get kicked out the door. It raises all sorts of insurance issues, et cetera, and so forth. So let's get to the triple scan. And I understand only one person in the room is using this right now. Just briefly, let me run through the scans. You have your choices. You can do a CT angio of the chest to rule out PE. You can do a CT of the coronary arteries. And you can do a CT of the aorta. Now, with the coronary arteries, you'll always get excellent views of the aorta. So what's the difference between why get an aortogram? Well, the difference on an aortogram is it goes all the way down through the iliacs. So on a CT coronary angiogram, you're just looking at the heart, so you get the arch and you get the thoracic aorta, but if you're really questioning a dissection, it doesn't go all the way down. The literature on millisieverts keeps changing. At our institution, a CT coronary angiogram is 5 to 6 millisieverts. I don't know if you know this, but a stress test, a nuclear stress test, is 8 to 10 millisieverts. So you get more radiation doing a nuclear stress test than you do with a CT coronary angiogram. A regular coronary angiogram is about 7 or 8 millisieverts. So at least at our institution, with the protocol used by our guy, you get your path to least radiation is actually the CT coronary angiogram. Now that jumps substantially when you're doing a triple study where I want to look at the pulmonary artery plus the coronary arteries plus the aorta. Then it jumps to about 12 to 15, and it's a little bit more than getting the CT pulmonary embolism for pulmonary embolism by itself. So that's sort of the scenario that we're working in. With a 64 slice, it takes about 15 seconds. With a 256 or 320 slice, it takes about 2 to 3 seconds to do these tests. Also be aware of some other things. A head CT on a 256 slice takes about 1/4 of a second to do. Think of all the peds sedations that we're doing now for some of these CAT scans. Now, just if they blink, you'll get the CT without artifact. A pan scan on a trauma patient takes about 2 to 3 seconds. I'd like to see this because I've not seen this yet, but it seems like if you move the body through that thing in about 2 seconds, you have to strap it down or else the body will just fly off the stretcher at the end. So I don't know how this is going to work. The other thing that will start to happen, and this is with 16 slice or better, you can do a beautiful CT angiogram of the head. I had a woman about a month ago that complained of, she had a long history of migraines, but she came in with a headache that was different 2 ways. One, it was lasting much longer, but the other is it was a thunderclap type headache. And her normal CT was negative, and I was going to tap her, but the radiologist, we were just in discussion about something else. He said, "Why don't you get a CTA and look at the head that way?" So I did, and she had a dumbbell-shaped aneurysm that actually went and got clipped. But you could see it just sort of stood out so easily. For strokes, those that are actually following the stroke protocol right now, it's a quick CT, and then if you have an MRI, you get a perfusion-diffusion scan. Well, with CT, 16 slice or better, you can get the same information, except you get it like this instead of having to go through the whole thing with MRI, which many of us in the room don't have easy access to anyway. So that's the context. Now, a lot of the literature on CT angiograms, coronary angiograms, talking about how perfect or imperfect it is. And I ask you, as you think about the literature, not just to look at the results, but you have to compare it to what we are currently doing with our patients that we admit to the hospital. And whether or not, so you think for yourself whether or not this would be an improvement or not. We are going to end at 9:30, so I'm going to spill this into my next talk tomorrow, which is on non-STEMI. So we'll go as far as we can, unless you guys like to stay till maybe noon, and we can chit-chat. So how do you do this study? If I'm going to send you for a coronary arteriogram, CT, you've got to have your heart rate less than 70. So I'm going to start you on, so that automatically is going to preclude some people. If I can't get your heart rate down, then you may not be a candidate. If you can't lay down flat and breath hold, you're not going to be a candidate. So somebody with an exacerbation of asthma or COPD or something, or with bad failure, where you already sort of have your diagnoses anyway, are not going to be good candidates for this. So I need to slow your heart rate down. You need to be able to hold your breath. During the procedure, you're going to be given nitro because they want to maximize the vasodilatation as they're doing the CT coronary angiogram. The CT coronary angiogram results in a 3-dimensional picture which not only gives you the degree of stenosis, but it also gives you much more information that you can never get by coronary angiogram as to how much calcium's embedded in the plaque and how much plaque you have. See, plaque starts in the muscularis and much deeper. You don't see this early on with coronary arteriogram, but you can get a sense of whether somebody is cooking a lot of coronary disease that's subclinical. So now you have to make sure that they haven't been taking Viagra or Cialis or Levitra. There incidentally has been no study I'm familiar with as to how often people are honest when you ask them, have you taken any Viagra in the last 24 hours? My suspicion is that some people are going to be embarrassed to tell you the truth. And then they're going to end up with their butt in a sling because you gave nitro and now they're very, very hypotensive. Anybody given nitro to somebody that's been on these things? Boy, we had one once that just stayed at 50 or 60 over Palp-1 pressors for about 45 minutes to an hour, while we needed nitroprusside to lower our pressures while we're treating them. One of my colleagues, knowing that someone had been on Viagra but that had dynamic changes, decided to try a nitro drip and start it at 1 mic a minute and bottomed out the pressure on this guy. So nitro. Now, what's the best part of Viagra advertisements? When you look at the advertisements, what do you watch it and you think of, well, what's really going to make them run out and get this product? What is the part of that advertisement that's the most impressive? Is the warning. You should contact your doctor if your erection lasts for more than 4 hours. You should contact all your friends if your erection lasts for more. I mean, what better advertisement than that sort of warning? You should contact your doctor if you're having too much sex and too much fun. So avoid this product at all costs. So let's get into how good is it. And here's here we need to establish a perspective on this. When you read studies on CT coronary angiogram as they compare to coronary regular routine angiogram, the routine angiogram is considered the gold standard. When something is elected the gold standard, the thing that it's being compared to can only be as good as it or worse. It can never be better than it because it's not the gold standard. Now, for instance, there was a study out of South Carolina where they didn't pick a gold standard. They just said, let's do CT coronary angiograms and routine coronary angiograms and count the number of lesions that you find on each. And what they found is that you found quite a bit more with the CT coronary angiogram than you did with the routine coronary angiogram. But this is, now what I know about coronary disease, which would fill a small paragraph maybe, is as follows. Is that once you get to 90-95% stenosis, you start to get predictable anginal symptoms. I go upstairs, I get chest tightness, whatever else. However, the people that drop dead, the people that come in with ACS, may not have a significant stenosis at all, but they'll have instead a ruptured plaque, which causes abrupt stenosis. And that may happen at a 50% lesion or a 30 or 20% lesion. So that what's the gold standard for what you're concerned about? Well, for chronic angina, it's going to be 90-95%. For ruptured plaque, there isn't really a gold standard for it. But in looking at this literature, this is the gold standard that was picked. We're going to do regular coronary angiogram, and we're going to look for whether or not the angiographer said this is a 50% lesion or more, or 49% lesion or less. And we're going to say that the CT coronary angiogram is sensitive if I match you perfectly. So here's a false negative. The coronary angiographer said that this is a 53% lesion, and the CT coronary angiogram said this is a 45% lesion. Oh, that's a false positive. You missed it. And that's clinically silly. So I'll stop at this point. We'll talk tomorrow about how this all pans out. But the way it's really going to pan out is that if you start to do this in your emergency department, you're going to start to find that there are patients with classic symptoms that end up having, when you do the CT coronary angiogram, they're clean. You're done. You can send them back to the Sahara Desert. You can send them back to their doctor. There's no point to getting a stress test. There's no point to getting a CT coronary angiogram, a routine coronary angiogram, because their coronaries are clean. And in the low-risk group, you'll see a fair number of patients that do this. Anyway, we'll continue this tomorrow, and it will interfere with the non-STEMI and possibly the STEMI talks, but they're just going through the new recommendations, and they're short and sweet anyway. Have fun going back to your room and studying all day.